Okay, welcome back, Concordia University Irvine students, HLMG 425, Financial Management of Health Services Organizations. We're in week 3 already, so this is your week 3 introduction. Thank you very much for all of the hard work over your first couple of weeks of the course. We are really starting to get into some serious issues now, so I'll let you know up front this video is going to be a little longer than the rest of the videos, and perhaps that may even be the case for the rest of the semester. I can tell you that these concepts in Chapter 3, third-party payments, Medicare, and reimbursement, they are perhaps the most challenging concepts that you'll have to grapple with at the undergrad level and at the graduate level. And to give you full disclosure, I really didn't start mastering these concepts until I got a master's degree. So some of you may find yourself struggling with these concepts, and it's okay, but it's very important that you grapple with it. The more that you grapple with it, the more that you'll take away the knowledge and the concepts that you're supposed to take away. If you don't grapple with it, then you're not going to get the building blocks and the lessons that you need in order to build those bridges of knowledge to master this concept. So in this week's session, we're in the introduction to financial management of healthcare organizations, chapters 5, 7, and 9. And so when we talk about this third party payer system, and I'm on page 94 for those of you that want to follow along, I want you to forget about healthcare for a minute, and I want you to think about your regular transactions, whether you're conducting business for services that are being rendered, or maybe for goods that you're purchasing or that you're even selling. It's usually just a two-party transaction. You have the buyer that sets the price. You have the seller that sets the price, and you have the buyer that agrees to the price. Once there is a meeting of the minds, you have the transaction, also known as the sale. And until you have the meetings of the minds, you don't have a sale, meaning that the seller or the producer of a good, why don't we call it a honeydew melon, may want to sell that honeydew melon for $2 each. Well, the buyer may not want to buy honeydew melons at $2 each. They may only want to buy the honeydew melon at $1.50 each. So you have the producer or the seller that has a price, and you have the buyer that wants to buy the product, but only at the price they want. At some point, through the quote unquote invisible hand, according to the great economist, Joseph Smith, you have this invisible hand of the economy that is constantly working at equilibrium of prices. And so at some point, the producer or the seller now decides to sell their honeydew melons at $1.75, and the buyer of the melon agrees that they could purchase the melons for $1.75. So you have that meetings of the minds. Well, that isn't the case in healthcare, is it? You don't have a two-party system. You have a three-party system, or what we call a third-party system. And I know many of you are familiar with the process as either caregivers or receivers of care. But you have the physician, one as being one party that makes that recommendation on a care plan or an intervention. And you could even have the patient that would agree with that care plan or that intervention. So in a normal circumstance, you would have a meeting of the minds. But in the healthcare system, there is a third party, and that third party is the payer. You have public payers such as Medicare, Medicaid, and you have private payers such as Aetna, Blue Cross. But the point is that there is a third party in that transaction that determines if the doctor's recommendation and your agreement with that doctor's recommendation either has a medical necessity or is somehow covered under the health plan or other types of variables that may happen. Maybe it's a high deductible plan and the co-pays haven't been met. But in the third party system, there is a third party there known as the payer that has a say in that transaction. And there's a really good example of it in Exhibit 5.4 on page 97. And the commercial payer here. Now, remember, those commercial payers, they are under a contractual agreement with the company to offer a specific set of benefits to the employee. And then they also contract with the medical provider to pay the bill. So you can see how that insurance company or that third party payer is a primary agent in this transaction because they have contractual agreements with the employer to and employee by extension to provide a set of specific benefits. And then they have contractual agreements, also known as capitation agreements, with the provider to render service to a specific panel of patients. And that gets into this whole idea there that we start talking about in Exhibit 5.5, which is the managed care process. And so a managed care organization is an organization that controls the cost of health care, the quality of care, and the access to care. And they do this through this idea called a gatekeeper. And this gatekeeper really is your primary care physician, and that primary care physician determines the level of service that you receive within that HMO. For example, let's say if you have a foot issue and you need to see a podiatrist, which is a foot specialist. Well, if you have a managed care contract, you either have an HMO or PPO. I'm on page 98 for those of that are following along. So the HMO has the gatekeeper. The HMO says that your primary care physician has to give you a referral in order for you to see the podiatrist. That's an HMO. Whereas the PPO, you can self-refer yourself to a specialist. You just have more of the financial responsibility in that transaction compared to someone in an HMO. But both of those programs fall under MCOs, what are also known as managed care contracts there, or managed care organizations, MCOs. There's also something known as an EPO as well, employer provided organization. It's kind of like a PPO, but it's more than an HMO, but less than a PPO. I don't think they actually talk about that in your book. So they go on here. I'm just kind of scrolling through pages 101. They talk about direct contracting plans occur when employers make contractual agreements directly with integrated care systems or healthcare systems by accepting the financial risk. Sometimes you'll hear that as being self-employed or self-contracted. insurance plans. I think Amazon right now is the big company that kind of self-insures their employees. When I was working for Healthcare Partners back in the early 2000s, we actually went away from our insurance plan, and Healthcare Partners started to self-insure also. You've got these consumer-driven plans which help individuals choose healthcare providers, and their financial incentives encourage to only request the appropriate amount of health services. These consumer plans come with primary models such as spending accounts and tiered models. And basically, what these tiered models do is they allow consumers to customize cost sharing parameters and deductibles and other ways to kind of control the out of pocket cost of their health care. And then you've got these high deductible plans that are actually pretty popular. I'm at the bottom of page 102 right now. And what it does is it shifts really more of the cost to the patient, but it lowers the premium. However, if there is some type of health care, and it's not even an emergency, just a healthcare intervention, these high deductible plans, the consumers have more of the out-of-pocket costs. So you still have insurance, you have lower premiums, but when it comes to utilizing the service, these high deductible plans can be very costly for the people holding the plans. However, again, they are very popular. In kind of closing out here on chapter 5, it talks about healthcare reform. By the time you're looking at this video, we are actually under a new presidential administration, the Biden administration. And so we'll just have to wait and see what happens. The accountable care, or the patient protection and accountable care, healthcare reform has gone through, I think now maybe this fourth time at the Supreme Court. And we just don't know. We know that under the Trump administration, the individual mandate was eliminated. And so we're kind of in flux right now. If I had to make an educated guess, I would say that the Biden-Harris administration will kind of put the infrastructure back into the Accountable Care Act, but we just really don't know what individual states are going to do, such as Texas and some of these other states that have been against the Accountable Care Act almost since the beginning. So I'm not going to spend a lot of time on the Accountable Care Act, but I will tell you to keep your ears to the ground and listen for these changes, because the changes that happen within healthcare reform are going to be the facts on the ground after you graduate and start working in healthcare in earnest. So some of these ideas here, and I'm working my way through pages 105 right now. We're talking about different payment methods here. And, that's kind of have always been a big deal with the rendering of health services, are the cost and the charges that are associated with it. Under President Trump, he did a really good job of signing executive orders to make pricing more transparent, as it dealt with both prescription drugs, but also hospital charges as well. So we'll have to see how those executive actions or executive orders continue to make the price of prescription drugs and health and hospital charges more transparent. Now, something also that affects these charges are the contractual agreements that insurance companies have with providers, also known as capitation plans, there may be contractual carve-outs where the insurance or the provider would, let's say, normally charge $500 for an MRI. But because they have a contractual agreement, there's been a carve out for MRIs for only $400, for example. This whole idea of per diem and per diem rates that we talk about here in these closing paragraphs of the chapter here talk about the creative way that providers are compensated based on per diem rates and not necessarily under a contractual agreement. So not really an on-call, but kind of an on-call thing, because the provider is only reimbursed for services that they rendered that day, for example. The book talks about capitation charges here at the bottom of page 106. Very important concept here when we talk about compensation or when we talk about capitation, because capitation is a fixed amount of compensation that medical provider is going to receive each month for that panel of patients. Again, it's a contractual agreement between the insurance company and the medical provider to render services for a specific panel of panel of patients at a specific price per month. And that provider will receive those charges whether the patient comes in or not. The provider still receives that capitation amount. Now, some of you counterintuitively may think that, well, if the provider is receiving services for patients, whether patients come in or not, then the providers are actually coming out in a better situation. Or forget about healthcare for a minute and think about the fitness industry. Some of you right now may have fitness contracts with 24-hour fitness or with some of the other fitness companies, and you may or may not be going to the gym every day. And so you'll say to yourself, well, if I'm paying $50 a month for my gym membership, but I'm not going to the gym, then the gym is actually coming out on top. And in this case, it is because you are not there to put the wear and tear on the equipment that would thus lead to higher costs for the fitness center that you're going to. But it doesn't work that way in healthcare. So if I am a provider and I have a contractual agreement with an insurance company to provide services for 10,000 patients under a capitation agreement, and I'm going to get paid whether those 10,000 patients ever show up in my practice every month. May seem like a good deal, but think about it. For all the patients that don't show up, what happens when they do show up? They're sicker, they need more of an intervention, and they utilize health services at a higher rate and more expensive health services, particularly as it relates to the emergency department. So counterintuitively, the patients that do not show up on a regular basis for their medical treatments actually end up costing the health system more money in the long run. And that's part of the different way that we have to think about healthcare and the third-party payer system compared to regular two-party payer transactions that are outside of the delivery of health services. So we're going to move on right now to Chapter 7. and talk about Medicaid. And depending on what state you live in, Medicaid may be known as a different name. Now, many of you are residents of California, as I was a resident of California for 35 years before recently relocating here to Southern Nevada. And so I know, and I know that you know, that Medicaid in California is called what? I can hear you say it now, Medi-Cal. And that's the beauty about Medicaid. So Medicaid is a co-sponsored health insurance for citizens, if you will. But there are certain conditions that have to be met in order for people to qualify for Medicaid and in order for states to participate in specific Medicaid, particularly Medicaid expansion under the ACA. In high income places such as Southern California, particularly Los Angeles County, and I'm pretty sure Orange County too. The county also chips in to help pay the price of Medicaid. And so when we look at Medicaid, at least in Southern California, is what we're going to talk about today. You've got the federal money that chips in, you've got the state money that chips in, and you have the county money that chips in. And that county money doesn't always chip in other locations. It just really depends on the cost of living. And of course, the cost of living is much higher in, let's say, Southern California than Southern Nevada, here where I live. And so you're going to see how the county can sometimes chip into if you are so many percentages under the federal poverty line. Now, you'll see here, starting on page 51, that Medicaid and also Medicare, by extension, are part of the Social Security Act of 1965. So then that tells you right now that in order to qualify for these services, you have to be a United States citizen, because your eligibility is tied to your Social Security number. Now, some of you that are unfamiliar, you may think that Medicare and Medicaid is actually the same thing, where Medicaid is known more of is a safety net type program for underprivileged or underserved citizens, whereas Medicare is actually an entitlement program that citizens pay into over the course of their working career in order to receive those benefits whenever they're entitled to it. And in some cases, it's age 65, but it could be a lot younger than that, depending on the circumstances. But Medicaid doesn't work that way. So about 50 to 80% of the cost of Medicaid in any given state has the significant authority to administer the programs. And so Medicaid, or Medi-Cal in our case, is going to look a lot different in California than it does in Nevada, than it does in Oregon, than it does in Washington. At the top of page 52, it talks about the financing and how there are two categories, which are the cost for provider services that are determined by predetermined formulas. And then there's the cost for administrative services on those services that are rendered. And so the financing from both state and local revenue, and when we say local, we're talking about the county here in Southern California, must be at least 40% and then the federal government can fill in the rest of that. What you'll notice here, for those of you that are already in healthcare, the reimbursement rates to providers are significantly lower for all public insurance, whether it be Medicare or Medicaid, but it is substantially lower for Medicaid. And I think what you have found and what we have seen over the course of the last couple of decades is that Medicare providers, or providers in general, are starting to purge their panels of both Medicaid and Medicare patients by extension. And so the whole reimbursement to providers are based on predetermined formulas. They're based on a mix of diagnosis related codes and methodologies and case mix. There's been some recent changes at the administrative level as it relates to value-based purchasing and value-based care that are starting to shift those percentages, but nearly nothing to the reimbursement levels that a physician could get from, let's say, a commercial insurer, for example, or from a customer with a high deductible plan, for example, or even a self-pay uh, patient for that matter. So if you take a look at Exhibit 7.1 and Exhibit 7.2, you'll get a good idea of the total medical expenditures in the country and the expenditures that were paid by Medicaid. Particularly as it relates to people that are most likely to qualify for Medicaid, and these are children and adults with some type of disability as well. Now, they have the elderly here. There may be elderly people that are known as Medi-Medi or dual eligible patients, but usually patients that are over 65, and obviously they're citizens and they have paid into the Medicare system, would also qualify for Medicare, but there may be patients that qualify for both. So sometimes you'll hear those plans referred to as Medi-Medi plans, and you'll hear the patients referred to as dual eligible patients. There is a gap. I'm in the middle of page 155 right now. Actually, I'm in the first paragraph of page 155, and it talks about this Medicaid gap between people who qualify for Medicaid and those who qualify for marketplace subsidies. And these are these health insurance exchanges that became popular under the ACA. Fraud, waste, and abuse are still significant factors as it relates to the cost of healthcare itself. And as a result of the rampant fraud, waste, and abuse within the system, it continues to put upward pressure on the cost of healthcare. And until we can somehow get that under control, you can certainly expect the cost to continue to go up as a result of fraud, waste, and abuse. And all you really have to do is just listen to the local headlines every day just to hear the type of Medicare billing or Medicaid billing that goes on. There was actually a recent case with NFL players that were billing Medicare for equipment and services that were not rendered. So, and that actually is a perfect segue right into Chapter 9. And Chapter 9 can be found on page 198 when we talk about reimbursement. And so when we talk about reimbursement here, and again, these concepts are very challenging. Let me give you an idea here. If you owned a mom and pop store and you purchase a can of Coke for 25 cents, and then you decided to sell that can of Coke to your consumer for $1.25, you have made a $1 profit, right? Pretty straightforward. Well, not in healthcare. Let's go back to that idea that we talked about earlier about MRIs. You have a medical provider that decides that we will provide MRIs for our patients at a rate of $500. That's the retail rate. Well, if your patient has a commercial insurer, that commercial insurer may reimburse you that entire $500 amount, or maybe very close to it, maybe $450 amount, right? This gets into this whole idea of payer mix. Well, let's say on the same day you have another patient that doesn't have commercial insurance. Maybe they have Medicare. And so it's the same MRI. You're charging the same $500, but the public insurer comes back and says, well, for MRIs, we only allow $400 for the MRIs. Well, guess what? When you get your reimbursement back or your electronic remittance back, you may have only received $350 for that MRI, because that's all the insurance company has paid. So you've got the retail price that the physician paid, that the physician says is $500. You've got the allowable charge of the insurance company, in this case, a public insurer that says the maximum we allow is $400 for an MRI. But when you receive your reimbursement check, you only receive $350. And if it was a Medicaid patient, you may only receive $300 for that MRI. If it's a self-pay patient, you'll probably receive the entire $500 because that patient is paying out of their pocket. If it's a high deductible plan, probably going to get close to that $500 reimbursement. So you can see now how this whole idea of payer mix can significantly affect your reimbursement rates and your revenue rates, either whether you're in a clinic or whether you're in a hospital or some other type of environment. And so those are the kind of tricky parts of healthcare finance and reimbursement that you're going to have to start grappling with to better understand it. If we have any business administration students in this class, you can certainly see how counterintuitive this whole idea is. I mean, think about it for a minute. What if you were contracting with a lawyer and that lawyer charges you $1,000 an hour? But then there's this third party payer that says, well, we only pay $800 an hour. And when the attorney received the bill, it was only for $750 an hour. Or think about anytime you go to a retail store and there's a difference between the prices being charged and the prices being paid. I'm saying all of that to say no one could probably stay in business that long with that type of a creative reimbursement or financing system, if you will. And so I'm going to challenge you to really start to grapple with this idea of healthcare finance as it relates to third-party payers, particularly public payers, and then as it relates to methods of reimbursement. I'm on page 208 8 right now at the bottom of the page. So you have these ideas here. These are the charges or retrospective reimbursement based on the charges submitted by the providers. Then you have charges minus discounts, and these discounts could actually be contractual carve outs or that were generated from capitation agreements, particularly if it's a private or commercial payer. You've got the cost plus. You've got these per diem rates that we've already talked about, and you've got the per diagnosis rate. And then finally, you've got the capitation rate as well. So study those. We'll continue to talk about those in week 3 and for the rest of the course because they are among the most challenging aspects of the course that we'll talk about here. Under the ACA of 2010, you've got value-based programs such as value-based purchasing, value-based rendering of services, hospital readmission reductions, and all of these incentive programs that are geared to connecting clinical outcomes to services rendered. And that's really the big shift with the ACA. It began to tie the outcome, the actual outcome of the intervention or the outcome of the actual clinical outcome to the rendering of services. And so that's part of the reason why you're seeing a lot of hospitals close here over the last 10 years because they have, in some cases, they have overbilled or overcharged Medicare and Medicaid. Medicare have now came back and said that they were overcharged and they're asking for their money back with interest. And also some of these hospitals, because of the fraud, waste, and abuse that we talked about at the beginning, and overcharging or upcoding is considered fraud, waste, and abuse, then these hospitals or these ambulatory organizations no longer qualify to participate in Medicare or in Medicaid. And so you've got a lot of stuff going on here as it relates to compensation, as it relates to reimbursement, as it relates to third-party payers, and some of these other concepts that we will begin to talk about in Module 3 and then further perfect throughout the rest of the course. So thank you very much for listening to this extended lecture today, and I look forward to building on these concepts for the rest of the course.